so I'll not be able to read this, but anyhow, this is what I'm feeling now. And we are here because of Isacos, and just to acknowledge this. Like he said, I live in Curitiba, Brazil. Is in South Village, this area with lots of trees, plants, and my house is here. This is the big city. And Curitiba is the city of the state of Paraná. This is the whole Brazil. It's almost the center of South America. And this is Paraná, and the capital city is here. It's called Curitiba. It's the city, the state before well-known Iguaçu Falls. Yes, it's a 1,000-kilometer trip, over 14 hours, but it's worthwhile here. Thank you so much for having us. So we're going to discuss a little bit about this. We have a little story. What the orthopedic surgeon of my group said one day to me, "Now you're a surgeon of 3 surgeries," because just right after my talk. And I said, "Why 3 surgeries?" "Yes, because you have only 2 surgeries as a knee surgeon. You have surgery 1 is meniscus, surgery 2 is ACL. Now you have surgery 3, which is MPFL. So we have discussed a little bit about stability. There's the static factors that hold the patella in place, which is the bone architecture, axis, the trochlea, the MPFL itself, that acts as a static restraint. Patellar instability is increase of the mobility between the patella and the trochlea, and this was stated by Noyes in 1989 as a definition of patella dislocation. And there's some predisposing factors such as the patella, the trochlear dysplasia, the patella alta, the increased K angle, genus valgus, VMO dysplasia, external tibial torsion, femoral neck inversion, ligamentar laxity, age, and female gender. So these are some of the predisposing factors that may happen on dislocation of the patella. Imaging exams, we have an X-ray for patella height, the trochlear dysplasia, loose bodies, CT scan for the Lyon protocol, MRI for chondral lesions, and for the chronic instability treatment, there's a variety of over 100 described surgical procedures on the literature, and the majority of them work with the tensor mechanism realignments, and then that means working with the dynamic stabilizers. David Dejour has stated the menu à la carte with the correction of all anatomic abnormalities according to what you find in your patient. And there comes the new studies on the MPFL with recent studies saying that it may be a good idea. For acute, we do repair, and for a chronic case, reconstructions. The MPFL is a main static for the patella, main restrictor for the patella dislocation, 40 to 80% of restriction of patella lateralization. Has a resistance of 280 newtons with the intense in extension. First torn structure on acute patella dislocation. There are several studies. The first study was by Kaplan, 1957. First described the MPFL as a term and called it the transverse retinacular ligament. Warren in 1979 was the first to discover to discuss the whole anatomy. Feller and some others have discussed also the anatomy. Is a second layer on the medial side of the mini, astrosynovial, a length of average of 5.4 centimeter, width of 5 to 30 millimeters. The origin is above the medial epicondyle insertion in the superior medial third of the patella, and below the VMO, with fibrous connections to the VMO. So we have these views here. There's pretty much what we have just said. The ligament itself comes from the superior third part of the patella and goes to the medial epicondyle. In this video here, we can see exactly how the ligament is. So it's a real structure. At first we're looking at it, it seems like it's part of the capsule, but we really dissecting it, you see this real ligament there. This is some MRI views of the torn MPFL. So there's a bone bruise on the lateral side, and you don't see the ligament here. The ligament will be there. And again, on this MRI views. Nomura has described it that it is distal to the adductor tubercle and superior posterior to the medial epicondyle. And Stephen has stated that it's superior to the femoral origin and inferior to the patella insertion. There are several in vitro studies. Hautama has shown in 17 cadavers a lack of repair of the medial structures leads to instability. He reconstructed the MPFL in 30 degrees. Ostermeyer in 5 cadavers in biomechanical studies showed that medial patellofemoral reconstruction leads to stability. And if he performed only the ATT medial transference, he had instability in those cases. Again, Ostermeyer, in a study of 2007 with 8 cadavers, he showed in biomechanical testings that the MPFL gives reconstruction gives stability to the patella, and the proximal realignment was putting the patella to medial in his studies. More in vitro studies like Bicos with 5 cadavers showing lateral distal osteotomy was used for increased skill angle. Following if he was doing MPFL reconstruction, it was done with 30 degrees of flexion and without, if he had some patella centralization without medial overpressure. And Elias showed that with computer analysis, when graft deposition and length errors occur, the medial overpressure occur. There is several ways of doing the surgery, and this is the first one to describe it was Helena Gomes, is a guy from Brazil, and he described it in 1992 for the reconstruction. There's some open phases that one can use the semitendinosis. This study of Steinmeier, 34 patients with 165 reconstructions. They had for shallow trochlea, no recurrence, follow-up of 2 to 10 years. Nomura 60 knees with 30 acute dislocation in 30 recurrence, initial scope and second loop, high percentage of chondral lesions and chondral cases, worsen over time if stability not corrected. MPFL reconstructions and with 10 years follow-up for Nomura had no patellofemoral arthritis. And this is the way we do it. This is a technique was described in arthroscopy 2007 by Camanho. It's a Brazilian guy from São Paulo. And we had a modification of it. And we've been doing this surgery since 1925. We first do a knee scope for loose bodies and chondral lesions. We evaluated the patellar excursion before and after doing the surgery. We use double incisions like this. So it's a single incision in the front where we harvest the patellar tendon and a single fission in the medial part. We just release the graft from the distal. We keep it close to the patella, attached to the patella proximally. We tunnelize it under the skin, so we just pass it under the skin and put it with holes there. First we do like this, we release it, sorry. We just strip it off, oops, sorry. We strip it off the patella like this, so the end of the bone will be there, so the tendon is stripped off the patella like that, and it's twisted towards 90 degrees towards the insertion side, new insertion side, like that, and then we fix it. We put a hole right in between the epicondyle and the guillotine. On X-ray, we have this kind of view, and then on physical examination, this is pre-op, and this is post-op with these incisions. So we have a static stabilization of the patella. This is the MRI of the same cases with the new ligament there. We have the views of them there. We had from 2003 to 2009, 60 patients, 68 knees, aged between 12 and 35 years old, 6 with open physis, which were treated with semitendinosus and bursitis, all with chronic patellar dislocations, 12 patients with previous surgeries like realignments, proximal VMO procedures, and lateral release. We had lateral release if it tense in the retinaculum, so the lateral patellar subluxation on scope, we perform the lateral release. If the Q angle is above 40, we do the distal realignment. That means 4 cases in our case series of 60. If the patella is high or the trochleus dysplasia, no influence in our cases, and there is no influence in terms of chondral lesion except for pain. Of course, if they have chondral lesion, they have more pain. Results, also again, full rehab with full weight bearing as tolerated with crutches, progressive range of motion, back to sports depending on muscle recovery within 3 to 4 months. Because of range of motion deficits, we have 2 cases of manipulations. Recurrent instability, we have 2 technical errors. That was on our learning curve. And these 2 guys were with higher TAGT on CT scans. So we perform distal realignments, and they are fine. And those with pain are those with arthritis that progress with chondral lesions. This is a result 1 month post-op, so you can really feel full range of motion. Just an example of the TAGT when we perform the distal realignment. This is with distal realignment also. And when we perform it with open physis, when we use just an anchor there and then use the semi-T. So MPFL reconstruction is a simple technique. Autograft patellar tendon with no proximal detachment, stable fixation on the isometric point, tensioning at 30 degrees flexion, scope for patellar excursion and evaluate the chondral lesions, immediate stability with early rehab, lateral release and ATT medialization if needed according to each case. In conclusion, MPFL reconstruction with medial third of the patellar ligaments, a simple, safe technique, good alternative for treatment of medial patella instability, excellent result of this case series of 60 cases. More studies and larger follow-up is needed, of course. We would like again to invite you for ISACUS next year in Rio. Of course, it will be a huge opportunity to visit my country. And shukran.